Welcome, everyone, to the first episode of a new podcast series, Diabetes Care on Air, a new and different way to bring the research in diabetes care to life. My name is Dr. Alice Chang, endocrinologist and associate professor at the University of Toronto, and it is my pleasure to co-host this podcast series with Dr. Michael Rickles. Hi, Mike.
Thank you, Alice, and welcome, everyone. I, too, am an endocrinologist and professor at the University of Pennsylvania. I'm delighted to have this opportunity to co-host Diabetes Care on Air together with Dr. Alice Chang.
This is going to be fun. Each monthly podcast episode will consist of interviews with authors of feature articles from Diabetes Care, along with a segment in which Mike and I get to nerd out on some of the other great content in that issue. And we may even have some special episodes with special guests.
Since this is a new series, though, we welcome your feedback and suggestions, so feel free to leave comments.
Well, let's get started. Since this is our first episode, it makes sense that we start off with a very special guest.
Yes, indeed. It is our pleasure to welcome the new editor-in-chief of Diabetes Care, Dr. Stephen Kahn, endocrinologist, professor of medicine at the VA Puget Sound Healthcare System and at the University of Washington, and director of the NIH-NIDDK-funded Diabetes Research Center at the University of Washington. Stephen is a prolific researcher on the role of the islet beta cell in diseases associated with disturbed glucose metabolism, with over 670 peer-reviewed publications. Welcome, Stephen, and congratulations on being the new editor-in-chief of Diabetes Care.
Thanks, Mike. It's indeed a pleasure to be here and chat with you and Alice.
So, Stephen, can you tell us a bit more about what inspired you to accept this role, and what is your vision for diabetes care moving forward?
Well, let me try and keep it brief, Alice. This could be an all-day conversation. I've done a lot of things in my career involving both basic and clinical research. I've truly enjoyed mentoring and collaborating with investigators in Seattle and elsewhere. And as an organization, the American Diabetes Association has been my professional society home from my very early days as a fellow. It has really been great to me, providing me with grants for my research and fellowships to support my trainees. And in fact, I got my first independent grant from the ADA. Subsequent to that, as I spent more time in my career, I've been an associate editor on a number of journals, including Diabetes Care, and I've always found it enjoyable and really quite stimulating. Thus, when I was asked if I was interested, I balked a little, thought about it at length, because it truly is a big responsibility. And I decided it was an opportunity to carry on the great tradition of prior editors, introduce some new initiatives, and of course, give something back. And so here we are. This podcast that the two of you have kindly agreed to be responsible for is one of the new things we're going to be doing.
Thank you, Stephen. And other than this podcast, what are some of the changes that readers of Diabetes Care can expect in the coming year?
So, Mike, we have a lot of new things we're trying to do, and not all of them are going to come online right away. But one of our major goals, which I think is really important to the authors, is to reduce the time from submission to an initial decision and then ultimately to publication. And we have actually been handling manuscripts since July. And if we just look at the data between July and now, we have already reduced the time to first decision by 50% compared to prior periods that Diabetes Care has been edited. This has been facilitated by the great work by the editors that we've appointed, as well as the staff in the ADA offices. And of course, this, I think, is going to be something that the authors will appreciate, and we're going to continue to work really hard at. The next thing that we thought about at great length is the issue of reviews. And we feel that the readership would really benefit from reviews that are written by experts in the field. And so we're going to try on a monthly basis to have at least one review that covers a variety of topics that we feel will be of interest to the broad readership of the journal. We're also looking to create special collections. So these would be thematic. For example, they could be on type 1 diabetes in general, or they could be specific to a certain series of articles. And we actually have a collection that will be appearing in the February issue that comes from the National Clinical Care Commission report to Congress on diabetes. This series of articles lays out what this commission, which was actually empowered by Congress, thinks needs to be done to enhance diabetes care in the US. And I think this is going to be incredibly important for our readership. The GRADE study is another example where there are a lot of manuscripts we expect that will be of value to people who look after patients with diabetes or people with diabetes. And all of these will be peer-reviewed, and we hope to bring a series of 4 to 6 of them together in one issue. I would say, in line with what I just talked about, we really want to publish more clinical trial manuscripts, and we hope to be able to increase the number of manuscripts as well as moving them through more rapidly, so that in fact some of them could appear simultaneous with presentations at major meetings such as the American Diabetes Association or the ASD meeting in Europe. And of course, we don't necessarily limit these to clinical trials. If there's breaking news that we think would be valuable, we would be interested in getting it, trying to reduce the time between submission and acceptance, especially if we know it's coming, and then try and work to get it done through publication and online. So those are some, but there's one important goal that I think I really want to highlight for our audience and ultimately for our readers. And that is, we plan to truly increase the focus on issues that are related to inequities in diabetes care. I think it's no question that we've all sadly seen the impact of racism in the US society with the murder of George Floyd. But it's not limited to this country. There's no doubt racism and socioeconomic injustice in many countries around the world, and they are key drivers of healthcare inequities within and also between countries. The editors of Diabetes Care as a group, which includes the two of you, all feel these inequities require serious and urgent attention. Therefore, at the journal, we're going to concentrate on themes of justice, equity, diversity, and inclusion in all that we do. This doesn't mean papers are all going to be about this, but we're going to ensure these are components of what we look at, and we're also going to have articles that focus on these issues. We hope that by doing so, our readers will consider and discuss these issues so that we all, as care providers, can together close the gaps that exist and impact the care for people with diabetes. And I would argue it goes beyond the healthcare providers. We hope this becomes general discussion in the community and in the political establishment. And as a starting point, we're going to require authors, therefore, to abide by standards that are now appearing in major journals in terms of what is required in terms of reporting on race and ethnicity, as well as sex and gender.
Wow, really quite amazing work and things that I think all of us look forward to, and clearly a lot of thought has gone into this. So wonderful, and thank you for sharing this with us. One of the things that's noticeable already this month is the change to the cover. Can you tell us a bit more about the plans for this?
Yeah, sure, Alice. This is also exciting. I think we all know Diabetes Care is a very typical cover with a picture on the front, and we're going to continue that theme. However, rather than it being an inset as a piece of art that has typically been obtained from a commercial source, we have changed the design in general. As you will see in this month's cover, the picture will fill the whole cover with the heading at the top and the featured articles at the bottom. But that's just the one component. To me, there's a much more exciting plan. And that is, we plan to feature the art of people who have diabetes or in some way or other connected to people with diabetes, whether it be family, friends, healthcare providers, or perhaps somebody even who's interested in diabetes but has no other connection but an interest. So as two examples, next month, we're going to have a drawing by a teenager who does not have diabetes, but has been impacted by friends with diabetes. She drew a piece of art which now hangs at the University of Washington's diabetes clinic and donated to the clinic to show where she sees diabetes in her life. And we've decided to feature that, and with that now go on to do more of this. So in March, I managed to get an endocrinologist who has type 1 diabetes and who works in New York to provide a cover art. He happens to be somebody who does art, which he has kindly done, which I think you will find really interesting and our readership will find interesting. It's really a collage and a self-reflection that will appear on the March issue. So I'd like anybody who's listening who has art that they make themselves, somebody they know who draws art, it could be a grandchild, for example, and it doesn't necessarily have to be something that's drawn. It could be a photograph, it could be ceramics, it could be anything that could be photographed, to think about submitting that to us for us to consider putting on the Diabetes Care cover. And instructions as to how to submit it are now part of the instructions for authors in the Diabetes Care on webpage and also at other places where you can access this information.
That's a beautiful plan, Stephen, and I think one that we'll all be sure to be looking forward to enjoying in the months to come. There's also been a change in the makeup of the editors. Can you tell us how things have changed on the editorial board?
When I took on this position or applied for the position, in the application, I laid out a number of things that I felt we should do. And the American Diabetes Association agreed to these. And so that's why I'm happy that we're able to do this. The important component of this was to restructure the makeup of the editors and to include diversity, equity in this as well as inclusion. And importantly to me, which has been a theme for all my life, is to encourage the development of early career faculty. And in this case, for them not to be scientists, but ultimately become editors. We also have now gone from an editor and a host of associate editors to an editor, 3 deputy editors who have different expertise, and people may know them: Liz Selvin, John Buse, and Cheryl Anderson. And then we've increased the number of associate editors so that these associate editors have diverse interests and really represent the field of what gets published in diabetes. And we've tapped outstanding researchers and clinicians like the two of you to play a role in moving the journal forward in the next few years. And of course, as we need, we'll be able to add more. And the American Diabetes Association has agreed to this. Now, in line with the goal of encouraging more early career faculty to consider being involved in this process, I'm really pleased to say that of all the editors of Diabetes Care as it stands today, 50% of them are either assistant or associate professors. But in selecting these individuals, we ensured we got the best of the best from these early career faculty. And I can tell you from working with all of them already now for 6 months, no regrets at all outstanding people who are providing great service to the community. Also, by trying to include more diverse race and gender, we've got a number of editors and editorial board members who are from other communities. And so what we see is that of the editors, 42% do not identify as white, and 2/3 now identify as female. And those editors, the associate editors, are located in the US, Canada, in Europe, Asia, and Australia. And when we look at the editorial board, it represents 13 different countries where diabetes is a serious problem. So part of this initiative is to really take the journal, and while it's an American-based publication, turn it into a truly international journal with international representation at all levels.
Well, clearly, this is an exciting new era for diabetes care. And thank you to you, Stephen, and to your team for creating this vision. And I think all of us look forward to being part of it and contributing to it and watching it grow and change. And in many ways, you continued with the tradition of presenting premier level scientific research whilst modernizing certain aspects to ultimately increase the reach and the impact. So thank you, Stephen, for your leadership and your vision.
And thank you, Alice and Mike, for taking on this important new role. I truly look forward to listening to, I would call it your work, but I think it's also going to be fun, and all the exciting things you're going to be sharing with us as an audience. And I could also say good luck, but I'm excited.
One of the feature articles from the January 2023 issue of Diabetes Care is titled Racial Disparities in Access and Use of Diabetes Technology Among Adult Patients with Type 1 Diabetes in a U.S. Academic Medical Center. I'm really looking forward to discussing this important study further. And to do that, I am pleased to welcome Dr. Mathioudakis, senior author of this paper, endocrinologist, and an associate professor of medicine at the Johns Hopkins University School of Medicine. Thank you so much for joining, Ness.
Oh, thank you so much for having me.
So, Ness, I wanted to congratulate you and your team for having this feature article in Diabetes Care. Can you begin by summarizing the study for us and its key findings?
Sure. So our study was exploring racial differences in diabetes technologies, continuous glucose monitors, and insulin pumps in adult patients with type 1 diabetes seen at our clinics. So this was a retrospective study conducted at the diabetes clinics at Johns Hopkins Medicine. We looked at clinical data from approximately 1,300 adult patients with type 1 diabetes who were seen over a 7-year period. This was all patients who were consecutively seen in our clinics. And, it was well known that there are racial inequities in use of diabetes technologies in children with type 1 diabetes, where there have been multiple publications, but there's been relatively little investigation in adults with type 1 diabetes, and that was the focus of our study. So our study looked at racial inequities at the level of 3 outcomes based on the expected sequence of events in clinical practice, starting with clinician-patient discussions, followed by prescriptions of these technologies, and then ultimately use of the technology by our patients. And I think that this is one of the most novel aspects of our study, is the fact that we were able to capture not only use of the technology, but the steps that happen upstream. That is, did a discussion happen with the patient and the provider? And did that result in a prescription for these technologies? Kind of getting at this concept of the clinician being a potential gatekeeper to these really evidence-based technologies. And so our study adjusted for factors that are known to influence the decision to prescribe or use diabetes technologies, things like demographics and social determinants of health, the patient's diabetes duration, their level of glycemic control, diabetes complications, as well as, health utilization. So the hospitalizations, frequency of follow-up in our clinics, and even the provider type that saw the patient, whether a physician or a nurse practitioner or a fellow. And what we found was striking and concerning to us. So for the outcomes of continuous glucose monitors, we found that compared to non-Black patients, Black patients with type 1 diabetes had nearly 50% lower odds of having a discussion with their diabetes provider about the technology, and a nearly 40% lower odds of having a prescription for the technology. And we found that overall use, whether at baseline entry into the study or incident CGM use, was substantially lower for CGM among Black patients as well. And for insulin pumps, we found that compared to non-Blacks, there was a 60% lower odds of prescriptions for an insulin pump, as well as overall lower use, about 30% pump use for Black patients compared to 64% for non-Black patients. So, what was notable to us and really concerning with these findings was that this racial disparity persisted after adjusting for various clinical factors and social determinant factors. So we really couldn't fully explain the racial association with, differences in clinical characteristics or social determinant factors of our patients.
Wow. So those numbers are really quite in
They're
your face,
They're
right?
staggering. Yeah.
They're kind of in your face and really make you think, I think, as a clinician. So if we take a step back, and you mentioned it very briefly at the beginning, what motivated you and your team to study this very important question?
Yeah, so the impetus behind this paper actually was work that I had done with a former fellow of mine who's now a faculty member at UCLA, Dr. Estelle Everett. So she had noted that as a fellow, that patients with type 1 diabetes who were being offered these technologies were often patients who were well controlled, who were doing frequent self-monitored blood glucose checks, had better A1C levels, and that struck her as odd that the people who were already better controlled were not being offered the technology that could help them. And so going into this study, we had actually hypothesized that it was going to be the patient's level of baseline glycemic control that would be the strongest driver of the decision to offer the technologies. And that after you account for their A1C at entry or their follow-up A1C levels, that any racial inequities would go away. So that's sort of where the idea came from. And then again, what our main focus in this study was the looking again at the steps that happen upstream of these patients' use of this, the sort of the discussion and the prescribing, that no previous studies had really looked at it from that perspective. And we wanted to understand, well, are we offering these technologies equitably to our patients? Are there provider barriers? Are there systems level barriers beyond those that are known at the patient level?
So your team did a great job about looking at the various variables, be they social determinants of health or patient characteristics that may impact things. But as you mentioned, despite adjusting for all of those things, the racial disparities persisted, which then begs the question, why? What do you
Right.
think are some of the potential reasons for why the racial disparities persisted in diabetes tech outcomes?
Yeah, it's a great question, and one we've really struggled with. We've had an honest look at ourselves at the practice level and thinking what could be driving this. Well, some ideas that we have are, one is during the 7-year period of the study, insurance and clinical practice requirements about who gets these technologies could have influenced this finding in a way that we couldn't measure. So early on, CGM prescriptions required that a patient demonstrate 4 times a day SMBG checks, or that they had met with a certified diabetes educator. We didn't collect that information directly from this retrospective review. It would have been labor intensive. We do know that studies have shown lower DSMT skills among Black patients, and that can be a provider level barrier to recommending the technology. But again, we would have expected that any differences in self-management skills among our patients would have translated into higher A1C levels that we would have accounted for. So that's still kind of speculative. At the time of the study, the criteria per the ADA for who gets a CGM were kind of gray. There was a lot of subjectivity. And so it was recommended to offer this to willing, motivated, and capable patients. And so that decision rests in the provider. And if race was being used as some proxy for social determinants of health, that could really create a potential bias. It's possible that there were factors related to shared decision making, sort of the quality of the discussion with the provider, the patient's trust in the provider, or even potentially racial concordance between the provider and the patient that could have affected their likelihood to use the technology. And we couldn't measure that in this study. And finally, we really can't exclude the possibility that there was an implicit racial bias at play with our providers. We hope that's not the case, but there's a fair body of evidence in healthcare generally saying that unconscious racial biases can influence outcomes.
You used the word gatekeeper earlier on, and I think that's the perfect word to use. And the whole concept of perhaps us as clinicians being judgmental, whether we realize it or not, and using a lot of subjective things and gatekeeping technology is something we all got to think about.
Yeah.
So what are the practical things you would suggest that we as clinicians can do to try to address these disparities?
Yeah, I mean, I think one thing that's going to help in this domain generally is the fact that the ADA guidelines have become less restrictive. So over time, it's evolved from CGM may be recommended to CGM is now universally recommended for patients with type 1 diabetes. So now that there are practice guidelines saying this should be offered to everyone, we can, as clinicians, start thinking about ways to standardize the process of identifying patients who are not using the technology and providing consistent information to our patients about the risks of benefits of these technologies while incorporating their values and preferences. So I think we need a standardized workflow in clinic to make sure that our own biases are not getting in the way. I think we need to not only track who's eligible, but track when the technology is offered but declined, so that we can develop interventions to reinforce the importance of these evidence-based tools, and that we can revisit the discussion at periodic intervals. So it's not just a one-time thing. Getting at this concept of provider gatekeeper and potentially implicit bias, I think we could all benefit from unconscious bias training. I know that at Hopkins, it's been a priority, and I have benefited personally from all of that training. And then the last piece I think that could help here is additional training in motivational interviewing. We get a lot of training in the, pharmacology and the management of diabetes, but very little in how do you sell this to your patient? How do you engage them? What do you do if they push back and they're not ready? What are some of the strategies you can use to be an effective engager with your patients?
I love those. And finally, then, Ness, what are the next steps? What other research do you think is needed on this very important topic? Because clearly, this is a gap that needs to be fixed.
For sure. Well, first, I'd say it would be nice to get other studies out of different health systems looking at this outcome sort of in the way that we did, just to see that our findings are generalizable to other academic centers or regions of the country with retrospective data. But what we really need is well-designed prospective studies to really do a deep dive and understand what are the potential causes behind these disparities. So a study, for example, where You do an exit interview for all of the patients as they're leaving the encounter with the clinician, and you ask them point blank, was this discussed? What did you think of the discussion? What could have gone better? And get more of their perspective on the ultimate reason they accepted or declined the technology. At Hopkins, we're testing some strategies to do better here. We have an ongoing NIDDK-funded study in our pediatric and adult centers to test whether a diabetes navigator, that's a lay person with a personal connection to diabetes, can help increase uptake and sustained use of these technologies. And we've also partnered with the Type 1 Diabetes Exchange QI Collaborative, where many practices throughout the country are developing and testing QI strategies to ensure equity in the use of these technologies for patients. And findings from these QI studies need to be published and disseminated and tested in various healthcare settings. And then I think in terms of the focus of future research, we need to look at the impact of the provider's training and experience. We know that the provider's own knowledge and level of comfort with technology may drive their decision to offer it in the first place, and we weren't able to explore that. We could look at the racial concordance of the patient and the provider, and then again, getting at the quality and quantity of the provider and patient discussions. Our study was looking at just use, like was it ever prescribed and started, but I think we need studies on sustained use. And then finally, we need more studies on ethnic disparities. So our study wasn't powered to really evaluate differences among Latinx patients.
Sounds like you're going to be busy. There's
Yeah,
lots of work.
I think there's a ton of work to do. Yeah, I mean, this opened the door. Yeah.
Yeah, there's a lot of work to do, and a very powerful topic. So thank you very much, Ness, for spending time with us today. And I encourage all of our listeners to read the full article in the January issue of Diabetes Care.
Thank you so much for having me.
Welcome to Diabetes on Air. In the January 2023 issue of Diabetes Care is a feature article entitled Prognosis After First Ever Myocardial Infarction in Type 1 Diabetes is Strongly Affected by Chronic Kidney Disease. I'm delighted to have the opportunity to discuss this important study and its findings with senior author Dr. Lena Thorn and first author Patrik Smidtslund. Dr. Thorn is an associate professor in the Department of General Practice and Primary Healthcare at the University of Helsinki, where Patrik is an MD PhD student. Welcome, Lena and Patrik, and thank you for joining us.
Thank you very much, and thank you for giving us the opportunity to come here and discuss our paper. And we believe that it brings a lot of new insight to coronary artery disease in type 1 diabetes.
Indeed. Patrik and Lena, congratulations to you and the Finnish Diabetic Nephropathy Study Group on this feature article. Your study sought to determine for an individual with type 1 diabetes experiencing their first myocardial infarction, what cardiovascular or disease-related factors are most important for influencing prognosis and risk for experiencing secondary cardiovascular events. Could you begin by telling us how you approached answering this question?
Well, first of all, in this study, we utilized a large nationwide cohort, the FINDIAN cohort, which includes almost 5,000 individuals with type 1 diabetes. And we also utilized the very good registries that we have available in Finland. So we started off to, via registries, identify all of our participants that have developed an MI during our follow-up. And then we ordered medical files for these patients and tried to characterize, first of all, of course, also confirm the diagnosis of the MI, and then to characterize all the MI and diabetes-related factors from the time point of the MI. For example, type of MI, the symptoms that they presented with, treatment modalities, and so on.
That's an impressively rigorous approach to capturing a complete data set. And the mortality rate of those individuals who experienced a first myocardial infarction was quite high in your cohort, nearly 74%. Is this what you expected?
That is a great question. First of all, our study included fatal pre-hospital myocardial infarction, and thus high short-term mortality was quite expected. Regarding the long-term mortality, the median duration of diabetes in the FINDIAN study is quite long in comparison with many other studies. and consequently complications associated with higher cardiovascular mortality, such as diabetic kidney disease, are comparatively frequent finding. Even so, the extent of the long-term mortality rates was somewhat surprising, highlighting the fact that we would need more means to prevent the myocardial infarctions in the first place.
That's great and really emphasizes how important getting comprehensive long-term follow-up data are for determining risk or outcomes. In your study, reduced kidney function as measured by the estimated glomerular filtration rate strongly influenced survival and the occurrence of secondary cardiovascular disease events for individuals with type 1 diabetes following a first myocardial infarction. Do you think as clinicians, we need to be more aggressive with primary cardiovascular disease prevention, targeting, for example, lipid parameters and blood pressure, beginning with even a mildly decreased GFR?
Yes, it is good to bear in mind that in our study we did not assess risk factors for a myocardial infarction, only factors affecting the prognosis after a myocardial infarction. Taking this into account, it is notable that a large proportion of those with MI had kidney disease. We did expect kidney disease to be a strong predictor of worse outcome, but what was interesting was that those with moderate chronic kidney disease had equally poor survival as those with more severe kidney function decline. The point of view that the study team would like to emphasize is the importance of preventing chronic kidney disease and its progression in the early stages. We, of course, acknowledge that these diseases share many risk factors, but we do think that taking good care of the kidneys is the best way to prevent excess cardiovascular mortality after a myocardial infarction in type 1 diabetes, and also to prevent the myocardial infarctions in the first place.
That is a terrific takeaway on how important kidney function is and how early in the disease process care should be taken for preserving kidney function. And given that the myocardial infarctions in your study occurred at a relatively young age, around 52 years, how does age of type 1 diabetes diagnosis influence when more aggressive cardiovascular risk factor reduction may become particularly important?
I think this is a very important point to raise, and we were surprised that the age was so young for those that developed the MI. It's partly driven by kidney disease, so that those with kidney disease got their MI at a younger age. But of course, I think one issue is in one of the risk models, we found that lower age at onset was associated with worse survival. So it might be, but I think it also reflects the duration of the diabetes. So of course, our data is, we can't really answer that question maybe directly, but I think indirectly, of course, maybe not as much as the age at onset is how long the diabetes have been lasting. So the longer the duration, the more aggressive we need to be with risk factor treatment.
Terrific. Another interesting finding for me in your study was that revascularization following first myocardial infarction was protective for both survival and the risk for experiencing a secondary cardiovascular disease event. Do you think screening for ischemic heart disease should be considered earlier, say after a certain duration of type 1 diabetes, or are more studies needed to inform such an approach?
Well, I think more studies are definitely needed, but and based on our data, we cannot really answer the question on screening. And in general, the revascularization and protective effect of it or effect on the prognosis is not as clear for stable coronary heart disease as for an acute MI. So to screen, we would need an effective intervention that actually affects the prognosis. So I think with the data today, I would still say that the most important thing is to treat the modifiable risk factors. And with respect to revascularization, one thing that we were thinking of is, of course, that with our data, we cannot answer the question if it's the revascularization per se that's associated with the better prognosis, or if it's still just a question of that those with the more severe disease that are actually just not the candidates for revascularization. That explains this finding.
Thank you. And while individuals who died during follow-up in your study were more often men, this sex difference in prognosis did not persist after adjustment for other risk factors. What implications do your findings have for managing cardiovascular risk reduction in women with type 1 diabetes?
First of all, what's not shown in the paper, but the risk associated with men having more worse prognosis was solely explained by kidney disease. So when we put kidney disease in the same model with age with sex, that already explained that sex difference. But of course, women with type 1 diabetes in the premenopausal ages are not protected from cardiovascular disease. And I think this also shows that they are not protected from the better prognosis after MI. So independent of sex, we need to be as aggressive with our treatments.
Thank you. And because your study was conducted in Finland, the population included was Caucasian. Are you able to speculate how your findings may be generalized to individuals with type 1 diabetes belonging to other racial groups?
That is an important question. We believe that the main ideas, such as chronic kidney disease driving the poor prognosis, are relevant for all ethnicities in the big picture. Ethnicity is known to affect the prevalence of diabetic kidney disease. For example, African Caribbeans with type 1 diabetes have a high prevalence of kidney disease. So results might not be directly applicable to other population groups. Unfortunately, the Finnish population of people with type 1 diabetes did not enable us to assess the role of ethnicity. We also believe that a complete lack of chest pain during severe myocardial ischemia is quite alarming for all individuals.
And so that really important message is how much all of this comes back to the kidney and how important preservation of kidney function from early in the disease course is important for type 1 diabetes, regardless of sex, race, or ethnicity. And finally, what other takeaway messages do you have for the readers?
Well, I think our take-home message or our main message is, of course, the kidney, that although the risk of cardiovascular disease has decreased over the years, the prognosis after an MI is still very poor. And I think other things that were important in our paper were those that were not associated with poor prognosis. For example, HbA1c at the time of the MI, the type of MI, smoking status at the time of the MI did not affect the prognosis. Although those things might drive the risk for an MI, there are different factors that affect the prognosis, mainly the kidney function.
Terrific. Such important insights for all of us. Dr. Lena Thorn, Patrik Smidtslund, thank you both very much for sharing your expertise with us today. I really appreciate all I've learned from your study and from our discussion, and hope that I can apply this new knowledge toward improved primary and secondary cardiovascular disease event reduction for my patients with type 1 diabetes. I encourage the listeners to access the full article in the January issue of Diabetes Care.
Now that we've heard about a couple of the feature articles in January's issue of Diabetes Care, Mike, let's briefly chat about some of the other interesting learnings from this issue, a segment that we're going to call Diabetes Care Rapid Exchange.
Great, Alice. Let's start with a study by Dr. Sarah Jane Cromer and colleagues that examined implementation of guideline-recommended initiation of GLP-1 receptor agonists and SGLT2 inhibitors among older adults with type 2 diabetes and either incident atherosclerotic cardiovascular disease or congestive heart failure using Medicare data. While initiation of both drug classes has increased, overall rates remain low, especially among those of Black and other non-white race, and in those living in areas with higher socioeconomic deprivation. This study thus highlights how improving access to guideline-recommended therapies that prevents widening of existing health disparities is critically needed for individuals with type 2 diabetes at risk for future cardiovascular disease and heart failure events.
That's certainly interesting because you're right. I think there continues to be major implementation challenges when it comes to these cardiorenal protective therapies. So very cool paper, and certainly one that I'm going to read. There's another one that I want to share with everyone, which is a review article on the etiology, epidemiology, and disparities in the burden of diabetes foot ulcers by Dr. Catherine McDermott and colleagues. And what struck me most was that the prevalence of both diabetic foot ulcers and lower extremity amputations is actually going up, especially among young persons with diabetes. And sadly, unsurprisingly, there are marked racial, ethnic, and socioeconomic disparities in these diabetic foot ulcer care. So the article goes through a number of strategies to try to reverse this trend, and it is definitely well worth the read.
Very important indeed, Alice. Another study was performed as an analysis of the Korean Health Insurance Service database conducted by Dr. Hung-Suk Lee and colleagues, which addresses socioeconomic disparity and mortality in individuals with type 2 diabetes. In this study, both sustained low income status and income drops, regardless of where someone's income started, were associated with increased mortality risk. Importantly, those with very low income status had a more than twofold increased risk of death, an association that was particularly strong again among young persons with diabetes, as well as among males. However, increasing income status was associated with reduced mortality risk. And that finding provides hope that future strategies to improve resources may help to lower diabetes-related mortality moving forward.
Yeah, Mike, I noticed that one too. This study, along with others, serve to remind us that the impact of the social determinants of health is, in fact, a global issue and one very much worthy of attention. So thank you very much for raising this one, Mike. Another one I found interesting and I think clinically very relevant is in the pregnancy space. So Dr. Daryl Sellin and colleagues did a retrospective cohort study of over 20,000 pregnancies and determined that over a median of 8.4 years, those who had gestational glucose intolerance, which is not a term that I had frankly been using before, but represents those who had abnormal initial screen but a negative confirmatory test, did have increased diabetes risk, and the adjusted hazard ratio was 2.01. This is very interesting to me since this is a group that I had not previously considered as high risk. And given the move in some centers to just do one-step testing for gestational diabetes, we may end up missing this group of women that we perhaps need to be having different conversations with. So I certainly found this study very interesting and, again, well worth the read for our listeners.
I couldn't agree more, Alice. Super important to have additional validated measures that are already, in many cases, being acquired in a woman's life to indicate who really needs to be more intensively considered for risk reduction strategies to prevent future diabetes. The next study I'd like to discuss is a randomized crossover trial conducted by Melissa Rosina Pasqua and colleagues that investigated the effect of low-dose empagliflozin as an adjunct to hybrid closed-loop insulin therapy in adults with suboptimally controlled type 1 diabetes. In this study, both a 2.5 milligram and 5 milligram daily dose of empagliflozin improved time and range similarly when compared to placebo during 14-day intervention periods and did not lead to an increase in ketone levels. These results support considering larger and longer term studies of the safety and efficacy of low-dose SGLT2 inhibitor therapy in patients with type 1 diabetes.
And being a proud Canadian, I can't help but mention that this was a Canadian-led study, I believe, and certainly one that, again, from a clinical practice perspective, can certainly make a lot of interesting changes. And then the final one that I think we'll share, and this is just a taste of some of the excellent papers that are in this issue. This is going to be of particular interest to you, Mike. Don Hoon Lee and colleagues looked at the relationship between long-term weight training and mortality among over 31,000 male healthcare professionals with and without type 2 diabetes. Bottom line, up to 150 minutes per week of long-term weight training, independent of aerobic activities, was associated with lower mortality. And if you did both, mortality was reduced by 20 to 34%. So, Mike, I don't know if you work out with weights, but if not, you should better start.
Well, thank you, Alice. I'm definitely going to take that clinical recommendation into consideration. Well, there's lots of other interesting learnings in the January 2023 issue of Diabetes Care. Obviously, a lot more that we were not able to get to, but it's now time for me to head off to the gym.
Good idea, Mike. So this brings us to the end of our very first episode of Diabetes Care on Air. A big thank you to Drs. Stephen Kahn, Mathioudakis, Lena Thorn, and Patrik Smidtslund for sharing their research and insights with us.
And a big thank you to all of you for tuning into this episode. We welcome your feedback, and don't forget to subscribe to this series and get notifications when a new episode comes out. Thank you for listening.